Asking what does the presence of anti-HBs indicate? And if you don't know, anti refers to antibody, HB refers to hepatitis B, and S refers to the surface antigen. So it's asking the presence of this indicates what? Hepatitis B acute infection, hepatitis B window period, hepatitis B recovery, or chronic hepatitis B low infectivity. Now this is a question that can be very straightforward if we know all the information for hepatitis B serology, but it can be a little bit tricky to get all that information down. So let's take it one step at a time. Now, first of all, hepatitis B is something that I'm sure you are very familiar with and are also hopefully vaccinated against. This is a viral infection that primarily affects the liver. Hepato does mean liver, and it can cause both acute and chronic liver disease. It is primarily transmitted through contact with infectious bodily fluids such as blood and semen, and it's commonly transmitted via sexual contact, the sharing of needles, or even exposure to contaminated surfaces. Because it is a form of liver disease, the symptoms include jaundice, fatigue, loss of appetite, abdominal pain, and dark urine, with chronic hepatitis B also causing joint pain and even liver cirrhosis, which is scarring. Now, treatment for hepatitis B depends on if it is acute or chronic. Most adults will recover from acute hepatitis B without treatment and often only need supportive care. Treatment for chronic hepatitis B includes antiviral medications, but complications such as liver scarring or liver failure can occur. But what's most important to know about hepatitis B for this question is the serological tests that are used to test and diagnose this condition. If you're not familiar with serology, it involves detecting certain antibodies and antigens in serum to diagnose diseases. So in this case, it will help us determine if someone has the acute form of hepatitis B versus the chronic form, as well as be able to tell us if someone has immunity, such as from a vaccine. Now, the three important antigens of the Hep B virus are the surface antigen, the E antigen, and the core antigen, and they're all written as HB, S, E, or C, and then AG, which refers to antigen. Now, when the body comes in contact with the Hep B virus, it produces three specific antibodies to those three antigens, which are named anti-HBs. So S would be surface antigen, anti-HBE would be for the E antigen, and anti-HBC would be for that core antigen. So this is how they're all written. Now, this question is asking, what does the presence of antibodies to hepatitis B surface antigen indicate? Now, even if you don't know much about the serology specifics, we can think about this answer logically. If we're producing antibodies to this antigen, then that would likely not indicate that we're currently experiencing an acute or chronic infection. Since we have these antibodies, we are experiencing C, hepatitis B recovery. So if a blood serology test is done on a patient and they have these antibodies to hepatitis B surface antigen, it indicates that they're either recovered from an acute hepatitis B infection or they were successfully vaccinated against the virus because they have antibodies to it. So if you needed to get a Hep B titer to start dental school, this is the antibody that they're specifically looking for because it shows you have immunity to the virus. Now, although this is definitely the correct answer choice, let's go through the others and discuss what the serology would show for each of them. Start with hepatitis B acute infection. Now, if someone is currently experiencing an acute infection, then they will have more antigens in the body, and in this case, that would be the hepatitis B surface antigen. The presence of this antigen indicates that the virus is currently present and infectious. Like we said earlier, the antibodies for the specific antigen will really only appear after the resolution of the infection and will then indicate recovery. So we know that this answer choice was incorrect because antibodies to hepatitis B surface antigen would not indicate an acute infection. Next, we have the hepatitis B window period. Now, to understand this answer choice, we need to know what the window period is. Now, this period refers to the time after the hepatitis B surface antigens have been cleared, but before the body has been able to develop the antibodies to this hepatitis B surface antigen. So during this specific period, neither the surface antigens or the antibodies are detectable, but the antibodies to the hepatitis B core antigen may be present. So we're not seeing surface antigens, we're not seeing surface antibodies, but we may see antibodies to the core antigen. So we know that this answer choice was incorrect because antibodies to hepatitis B surface antigen would not be present during the window period. And finally, we have chronic hepatitis B, low infectivity. Now, if someone has a chronic hepatitis B infection, they would still likely have hepatitis B surface antigens present, and the antibodies to these surface antigens would not be detectable. People experiencing chronic hepatitis B may also have antibodies to the hepatitis E antigen, but not to the surface antigen. So we know that this answer choice was incorrect because antibodies to hepatitis B surface antigen would not indicate a chronic infection. So Just to reiterate, because that was a lot of antigens, a lot of antibodies. When you have an acute infection, you will just have hepatitis B surface antigens. When you have a chronic infection, you will have some hepatitis B surface antigens and also some antibodies to the hepatitis B E antigen. When you're in that window period, you will not have any surface antigens, you will not have any surface antibodies, but you may have antibodies to the C antigen. And when you have cleared an acute infection or when you have gained immunity through a vaccine, you will only have antibodies to the hepatitis B surface antigen. So for this question, specifically, the presence of antibodies to the hepatitis B surface antigen would indicate hepatitis B recovery or immunity through a vaccine.
This question asks, what radiographic finding is indicated by the letter A? So the letter A here would be the ramus of the mandible, and this may present in a ghost image or in an image in general if the patient is incorrectly positioned or if they have just a different anatomy. So let's take a look at some of our answer choices and see why they're wrong and where these anatomical landmarks would be. So next we have the spine ghost image. Since this is on the midline, this would show bilaterally and the ghost image will always appear higher and a little more blurry. So this is what it would look like if we had a ghost image of the spine. Next we have the ghost image of the hard palate. This would present in this area, and the soft palate ghost image would present in this region. So hopefully now you have a good idea of where these anatomical landmarks are in respect to the mandibular ramus ghost image.
We have a male, he's 20 years old, and he says, I have a painful swelling on the roof of my mouth. We're given a lot of background information that we don't really need to focus on right now. Now, let's focus on the findings. We have a firm, painful swelling seen on the right side of the palate. It has a sunburst appearance noticed on the maxillary radiograph, and the periodontal ligament spaces are widened, and we need to know what this patient most likely has. So we're given plenty of information to make this diagnosis, but let's focus in on the really important things that we have here. First is the fact that this is a painful swelling. A lot of oral pathology lesions that we're told about are painless. They expand and they grow, but they don't usually show pain. So the fact that this is a painful swelling is a really important detail. Also the fact that it has this sunburst appearance noticed on the maxillary radiograph. Now radiographically, when we have something like this, like a buzzword to describe how it looks, that's always going to be associated with a certain condition. So knowing sunburst appearance was kind of a giveaway in this question. Another final important thing is the fact that we see these periodontal ligament spaces widened. So different oral pathology lesions affect the surrounding tissue differently, and the fact that we're seeing this widening of the PDL spaces is really important. Another important detail that I just kind of want to point out is the fact that he is pretty young, so it's also something that you want to keep in mind when we're making our diagnosis. And in this case, this patient most likely has an osteosarcoma. Now, I've attached a picture here so we can kind of see what one looks like, but an osteosarcoma is a malignant neoplasm of bone. It's pretty uncommon, but it is the most common primary bone malignancy. And 8% of all osteosarcomas affect the jaws. They're usually seen in long bones, usually the knee, but 8% affect the jaws. So we can definitely see it when we take a panoramic radiograph or anything like that. It's also commonly seen in young adults, kind of like I said, this patient is pretty young, and the average age for an osteosarcoma of the jaw is only 28. Now let's go ahead and talk about how our other clues that we were given were important. So I said that this is a painful swelling, and that was important. And the fact is that pain is actually usually the initial complaint for someone who has osteosarcoma. They start to feel this pain, and that brings them into the dentist. They take this x-ray, and that's when we would see it. But other symptoms can be swelling, loose teeth, they could have some numbness in the area, but pain is usually that first sign for them. Also radiographically, we always see this sunburst pattern like we're seeing in this x-ray. You can kind of see they look like sun rays, those little lines, and that's due to the cortical destruction and expansion of the bone. So that's what we're seeing here, and that description is always a giveaway for osteosarcoma. We also see a mixed radiolucent or radiopaque lesion with ill-defined borders, and we always get this symmetrical widening of the PDL in the teeth of that area, but the teeth will test vital. That's also an important detail because some lesions will lead to teeth that do not test vital, but in this case they do. So it's definitely what we're seeing here, but let's go ahead and talk about the other answer choices and how they are not what we're seeing. So an ameloblastoma, this is a tumor of odontogenic epithelium, so it's more tooth structure, it's not bone, it's not a bone malignancy, and it is the most common odontogenic tumor. It's known for being locally aggressive, slow growing, and the expansion it has can be dramatic. So this will grow, slowly, but like a lot. How is this similar to the osteosarcoma? We see it in a similar age group. 33 is the average age of diagnosis, so that's something that's in common, but it's mostly different. Things that are different is that this is a benign lesion, not malignant, like we saw for the osteosarcoma. This is painless, definitely not a painful swelling, not something you would feel and notice. This is also most common in the molar or ramus region of the mandible, so that's an important detail to know, but it can occur anywhere in the mouth. It can also be associated with impacted teeth, and we didn't see that for our osteosarcoma. Radiographically, we would see a unilocular or multilocular lesion with well-defined borders, and like I said, it's very expansile. And kind of the buzzword for this, in comparison to the sunburst appearance for an osteosarcoma, here we're seeing this soap bubbled presentation, and you can kind of see that in this picture here. It almost looks like a bubble bath. That's what we're seeing for an ameloblastoma. Now for a Pinberg tumor, this is also known as a calcifying epithelial odontogenic tumor. So once again, this is like a tooth tumor, odontogenic, and not a bone tumor like our osteosarcoma. So this is a tumor of odontogenic epithelium. Now, this is not very similar to our osteosarcoma. We see some expansion, but that's really about it as far as the similarities. Different, this is asymptomatic, so once again, not painful, and it's often associated with impacted teeth. The average age is 40, which is pretty older, a lot older than that 28 that we saw for osteosarcoma, because osteosarcoma is known for affecting younger patients, and a Pinberg tumor really is not. This is also usually seen in the posterior mandible. Now, radiographically, we would see, if we look at this picture, a well-circumscribed radiolucency when it's small, and then if it kind of expands enough, we'll see a multilocular lesion. The margins are usually well-defined, but they can be ill-defined, and the buzzword for this radiographic lesion is the driven snow pattern. So for osteosarcoma, we had sunburst appearance, for the ameloblastoma, we had soap bubble, and here we have driven snow pattern. Now let's go ahead and talk about the Gorlin cyst. This is also known as a calcifying odontogenic cyst. So we have a lot of names for these lesions, and it probably arises from some remnants of the dental lamina during tooth development. Now, how is this similar to our osteosarcoma? It's asymptomatic, so once again, not painful, and it's often associated with impacted teeth. The average age is 40, which is pretty older, a lot older than that 28 that we saw for osteosarcoma, because osteosarcoma is known for affecting younger patients, and a Pinberg tumor really is not. This is also usually seen in the posterior mandible. Now, radiographically, we would see, if we look at this picture, a well-circumscribed radiolucency when it's small, and then if it kind of expands enough, we'll see a multilocular lesion. The margins are usually well-defined, but they can be ill-defined, and the buzzword for this radiographic lesion is the driven snow pattern. So for osteosarcoma, we had sunburst appearance, for the ameloblastoma, we had soap bubble, and here we have driven snow pattern. Now let's go ahead and talk about the Gorlin cyst. This is also known as a calcifying odontogenic cyst. So we have a lot of names for these lesions, and it probably arises from some remnants of the dental lamina during tooth development. Now, how is this similar to our osteosarcoma? Well, it expands the alveolar bone. The mean age is 30, which is very similar to that 28 that we saw for an osteosarcoma. It's also usually intrabony, like that osteosarcoma was, but this is still an odontogenic cyst. It's not anything to do with a neoplasm of the bone. So this can also be seen in the soft tissue, and then it would be known as a peripheral calcifying odontogenic cyst, but it's usually in the bone. And it can also be a mixed radiolucent radiopig lesion like we saw for the osteosarcoma. Now, this is different in the fact that we see this in the maxilla and the mandible, but it's usually in the incisor canine lesions 65% of the time, and it usually has these well-defined borders. Radiographically, it's well-defined, unilocular radiolucency, and we usually see this scattered radiopacity, kind of like we see in this image. We see that most of the time. It can also be associated with an impacted tooth, and it can resorb and cause divergence in nearby tooth roots. So that's not necessarily the same as seeing that periodontal ligament space widening. We're seeing divergence, and we're seeing even resorption of adjacent roots if it's expanding enough. So we always want to keep in mind that when we have a sunburst appearance, when our patient is complaining of pain, and when they're pretty young, we want to keep in mind that we usually will have an osteosarcoma. Sunburst appearance is always a giveaway term for an osteosarcoma. This question is asking each of the following is a classic symptom of diabetes mellitus except one. Which one is the exception? Polyphagia, polydipsia, polyuria, or polymyositis? Now this is a great question as the 3 P's of diabetes are really important symptoms of diabetes to be aware of, and all these answer choices start with P, they all start with poly, they all sound really similar, so we want to make sure we know these. Now before we talk more about diabetes, let's start by defining each of these answer choices as they may be terms that we're not familiar with. We'll start with polyphagia or hyperphagia. This comes from phagia, which refers to eating, and hyper or poly would be excessively or many, so this term refers to a feeling of extreme hunger or the urge to eat more and more. Polydipsia comes from dipsia, which means thirst, and poly, meaning many, and this refers to excessive or extreme thirst or an urge to drink more and more. And then polyuria comes from urea, which refers to urine, and poly, meaning many, once again. So this is excessive urine production or having to pee a lot and quite often. And finally, polymyositis comes from itis, meaning inflammation, myo, meaning muscle, and poly, once again, meaning many. So this refers to an inflammatory disease characterized by generalized or many muscle weaknesses throughout the body. But let's get back to diabetes, and we can figure out which of these answer choices is not one of its symptoms. Diabetes is a group of metabolic disorders resulting in hyperglycemia, which is an excessive amount of glucose in the blood, and it's a defective or deficient production of or response to insulin. Insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. There are 2 major types of diabetes that I'm sure you are aware of, type 1 and type 2. Type 1 diabetes is a chronic autoimmune disease where the beta cells of the pancreas get destroyed by self-reactive T cells and autoantibodies, which results in absolute deficiency in insulin production. This is typically seen in younger patients and is characterized by decreased blood insulin. Now, type 2 diabetes is not an autoimmune disease and is either the result of insulin resistance or decreased insulin secretion. The target tissues may not be responding to the produced insulin, or the pancreas may not be producing enough insulin for the body to function. This is seen in older patients and it's associated with obesity, but the insulin levels in the blood may be normal or increased depending on the cause of the condition. Now, both types of diabetes can have a number of complications and symptoms. Diabetes is the leading cause of end-stage renal disease, blindness, and lower limb amputation, and has a number of other complications. As far as symptoms, the 3 P's or the 3 polys of diabetes are very common and likely the most well-known symptoms, and they would be polyphagia, which is extreme hunger, polydipsia, extreme thirst, and polyuria, increased urine production. Polymyositis is not one of the symptoms of diabetes, making the correct answer D. And once you know the definitions of these 4, it may seem pretty obvious that this was the odd one out. This is a completely separate condition, and it's not associated with diabetes at all. The generalized muscle weakness seen in the condition usually develops gradually, and it's most common in adult women. The exact cause of the disease is unknown, and it primarily affects the muscles closest to the trunk. Beyond difficulty moving, this condition can also cause difficulty swallowing, breathing problems, and increase the risk for aspiration pneumonia. Unfortunately, there is currently no cure, but treatments to improve muscle strength and function range from medications to physical therapy. Although we know the other answer choices all definitely are symptoms of diabetes, let's go through them really quickly and talk about why. First, we'll start with polyphagia. This extreme hunger is a result of a diabetic's body not being able to regulate and store the glucose it is consuming. Because the body is unable to make insulin or use it properly, that glucose will build up in the blood and not be used for energy. This leads to a lack of energy and makes the body think that it has not consumed enough glucose, leading to an increase in hunger to try and increase those glucose levels. Polyphagia can also be experienced by diabetics going through hypoglycemia rather than hyperglycemia, which is low blood sugar levels, which is also common in diabetics as their blood sugar levels are not controlled. Next, we have polydipsia. Now, this extreme thirst is basically an urge to drink fluids at all times, and this feeling can last for days to weeks to months without feeling satisfied or quenched. This occurs once again due to the fact that insulin is not properly regulating glucose levels in the body. Because of this, glucose is not getting stored for energy, and there's excess in the blood, making the kidneys have to work overtime to absorb and filter out all that excess sugar, all that excess glucose. And this is also why diabetes is associated with renal disease, as it's putting this extra stress on the kidneys. When the kidneys just can't keep up with filtering and absorbing all that glucose, they will flush out the extra glucose through your urine. And due to the way kidneys work, which we won't go into all that, they'll pull fluid from your tissues to be able to flush that excess sugar out of your body, leaving you dehydrated and constantly thirsty. And then finally, polyuria, which is increased production of urine, kind of goes hand in hand with what we just discussed with polydipsia. The excess glucose in the body that the kidneys are unable to absorb will be excreted in the urine. And because there is so much excess glucose that needs to be excreted, a diabetic will have an increased need to pee. They're also constantly thirsty and likely consuming more fluids because of that, so it just makes sense that this would lead to an increased urine production. They kind of go hand in hand. So we know that when we're talking about the symptoms of diabetes, the 3 P's of diabetes, really common symptoms, are super important, and they represent polyphagia, polydipsia, and polyuria.
This question asks, what is the radiographic finding indicated by the arrow? So this is on the left side of the panoramic radiograph. So this is not the patient's left earring, non-odontogenic pathology, or a cleft palate repair. Instead, this is a ghost image. And a ghost image is an image generated by a metal object between the X-ray source and the focal center of rotation. Now, this specifically would result in a duplicate ghost image on the opposite side of the original location of the metal object. This would be blurry on the contralateral side and superior to the real image, enlarged and laterally distorted. Since this is on the left side, we would know that this is the patient's right earring and not the left, making option A the correct answer to this question.
We have a 46-year-old female who says, "It hurts when I swallow and turn my head." She's taking ibuprofen and her blood pressure is a little bit high, but is normal. And we're asked, what is the most likely cause of her pain? Now, the biggest and really only clue we're given here is the patient saying, "It hurts when I swallow and turn my head." But this is honestly the only clue we need to answer this question. Even if we didn't automatically know that the correct answer is always associated with complaints of pain when turning the head and trouble swallowing, we can think about the area that moves when we swallow and when we turn our head and can kind of rationalize what area of the body our answer choice will be in. And in this case, the cause of the pain is D, a calcified stylohyoid ligament, which is also known as Eagle syndrome. Now, the stylohyoid ligament is a ligament of the upper neck that extends between the hyoid bone and the styloid process of the temporal bone. When this becomes calcified or elongated, it is known as Eagle syndrome or stylohyoid syndrome, and it's known to lead to pain when turning the head and when swallowing. This abnormal calcification can be asymptomatic, but others experience this characteristic head and neck pain, pharyngeal discomfort when swallowing, painful tongue movements, and headaches due to the calcification interfering with the function of neighboring structures. Patients who are affected by this are usually greater than 30 years old, and this can be a unilateral or bilateral finding. The exact pathogenesis for this calcification is unknown, but it's rather easy to diagnose once a panoramic x-ray is taken. If you look at the yellow arrows in this image, you can see the bilateral calcified ligaments. So if a patient has these symptoms, you take this panoramic x-ray and you can pretty clearly see, oh, they're calcified. That's what explains the symptoms. Now, this condition can be managed either conservatively or surgically, with conservative treatments including analgesics, steroid and lidocaine injections, and topical heat application. And then surgical would obviously be surgical intervention. Now, although this is definitely the correct answer choice, let's go through the other answer choices and discuss what they are and how they're different and similar from a calcified stylohyoid ligament. We'll start with sialadenitis. Now, this is inflammation of the salivary gland that can either be acute or chronic, with the chronic form being associated with salivary duct damage. This inflammation is typically caused by a bacterial infection, but can also be caused by things like mumps or ductal obstruction. Clinically, this presents with a diffuse unilateral swelling that is painful or tender, especially around meal times as someone has an increase in salivary production. The gland may feel warm and the overlying skin may be erythematous, as we see in this patient. The acute form of the condition is most commonly seen in the parotid gland, while the chronic form is usually seen in the submandibular gland. Treatment for this includes hydration, pain medications, warm compresses, massaging the gland, broad-spectrum antibiotics, and even surgical gland removal depending on severity. Now, how is this similar and how is this different from our Eagle syndrome? Now, they both can cause pain, but that's about it for similarities. Now, this affects the salivary glands, and in a patient with this condition, we would see a swelling and a tenderness that is not seen in Eagle syndrome. Sialadenitis also would not cause pain when turning the head. This condition is centered around inflammation instead of calcification, and this is also usually due to a bacterial infection, while the cause of Eagle syndrome is not well understood. And next, we have a tonsillolith, which is also known as a tonsil stone. The word literally just breaks down to tonsil and lith just means stone. Now, these are small yellow or white calcified masses that form in the tonsils, specifically in the tonsillar crypts. They form due to debris such as calcium, food debris, and bacteria getting trapped in these crypts. It's kind of like a maze, and then becoming calcified. The main symptom for patients is bad breath, but they're also known to cause sore throat, discomfort when swallowing, and a cough. Because they are calcified, they're not only able to be seen clinically, but you can see them radiographically as well, as you can see in this picture. Those tiny little dots are in the tonsils. Now, these can usually be removed by coughing vigorously, gargling with salt water. Some people use a water pick or a cotton swab to get them out. But if a patient is repeatedly getting these uncomfortable tonsil stones, then they may recommend a tonsillectomy, just taking the tonsils out. Now, how is this similar and how is this different from Eagle syndrome? Both are calcifications that are radiographically visible, even though they're obviously in different radiographic locations, and both may cause discomfort when swallowing and are commonly asymptomatic. Now, how are they different? Now, tonsil stones are due to the calcification of debris and are usually easily removed, while Eagle syndrome may cause discomfort when swallowing and are commonly asymptomatic. Now, how are they different? Now, tonsil stones are due to the calcification of debris and are usually easily removed, while Eagle syndrome is associated with a calcified ligament that would be more difficult to treat. Eagle syndrome is also associated with pain when turning the head and not bad breath, like we saw in tonsil stones. And next we have a rhinolith. Now, rhino just refers to nose. If you've ever heard of someone getting a nose job, it's called a rhinoplasty, so rhino just means nose. And we already said that lith just means stone, so this would be a calcification found within the nasal cavity. Now, these are very rare and result from a chronic inflammatory response to an intranasal foreign body. When a foreign body is introduced to the nasal cavity, it will act as the nucleus in the formation of a rhinolith. So salts will begin to deposit on that foreign body and encrust the lesion to form a stone. Now, these foreign bodies can be endogenous, such as a blood clot or a bone fragment, or exogenous, such as beads or fruit seeds that kids stick up their nose. They're most common in children and cognitively impaired adults who are more likely to insert foreign bodies into their nose. Rhinoliths have various clinical presentations, but symptoms usually include unilateral purulent nasal discharge, foul odor or foul smell, and nasal obstruction. These are usually found incidentally on panoramic radiographs, and treatment would be surgical removal. And you can see it on this x-ray. It's located farther up, and it's in the nose area. Now, how is this similar and how is this different from our Eagle syndrome? This is also a calcification that can be seen on a panoramic radiograph, once again, in a different location, obviously, but that's about the only similarity. This is a calcification of a foreign body, whether endogenous or exogenous, and it's not the calcification of a ligament. Rhinoliths do not cause any pain when swallowing or turning the head, and are instead associated with discharge and nasal obstruction. So when you have a patient who comes in and they say, it hurts when I swallow and it hurts when I turn my head, you should always take a panoramic radiograph and see if their stylohyoid ligament is calcified and if they have Eagle syndrome. We have a 30-year-old female who says, I have a bump in my mouth and sometimes it bleeds. She's 9 weeks pregnant and the lesion has been present for 1 month. And we notice this raised, pedunculated, speckled red lesion that is 20 millimeters by 10 millimeters on the interdental gingiva and palatal mucosa between the upper left canine and first premolar, and there are no radiographic findings. And we're also given this image to look at what's being described. And we're asked, what is the most likely diagnosis? Now, we're given a lot of helpful information to be able to make this diagnosis. The first important thing is obviously the description of this lesion and its presentation that we can see in the image. It's raised, it's pedunculated, it's red, and it's found on the interdental gingiva. This certainly allows us to narrow down the diagnosis when we think of all the diagnoses that are ever available, but we'll actually need even more information and specific clues from the patient box to make the final diagnosis, as a lot of these answer choices can present very similarly. A huge clue and indicator of the correct diagnosis is the fact that this patient is pregnant. The correct answer is associated with pregnancy, while the other answer choices are not. I also want to point out the fact that the patient reports sometimes that this lesion bleeds. This tendency is also more common in one of these answer choices when compared to the others. Based on the description of the lesion, its location, the fact that the patient is pregnant and the lesion bleeds, this is definitely D, a pyogenic granuloma. Now, what is a pyogenic granuloma? Now, this is a fibrous, benign, mesenchymal tumor that is a reactive lesion. It's an exuberant response to local irritation or trauma, and it frequently occurs during pregnancy due to the hormonal effect on vasculature. Clinically, it's a painless, rapid growth that is a speckled, reddish purple. It can be sessile or pedunculated, and it's usually smooth. It's often ulcerated, and it bleeds pretty easily. It can be found on any body surface, but 80% of the time, it's found on the gingiva when seen intraorally. Histopathology for this lesion would show vascular granulation tissue, including fibroblasts, capillaries, and inflammatory cells in a loose extracellular matrix. And that vascular granulation tissue, that vascular tissue in general, is the reason why it bleeds so easily and why it's able to have such a hormonal effect when someone is pregnant. Now, this would be treated via excision and removal of any irritants, since it's caused by trauma, but 15% will recur. Now, even though we know this is the correct diagnosis, let's go through the other answer choices and discuss what they are and how they're similar and how they're different from the pyogenic granuloma. I do want to point out that two of the other answer choices, the peripheral ossifying fibroma and the peripheral giant cell granuloma, are often grouped together with the pyogenic granuloma and are often differential diagnoses for similar lesions. I was always taught them as the 3 Ps when a patient presents with a bump on the gums. There are certainly a lot of similarities between these lesions that you'll notice as I discuss them, but we'll also be sure to talk about how we could differentiate them from each other and know that this specific lesion was a pyogenic granuloma. We'll start with the peripheral ossifying fibroma. Now, this is another fibrous, benign, mesenchymal tumor that is also a reactive lesion caused by local irritation or trauma. Clinically, it is painless, firm, coral pink, and it may be ulcerated. This is only found on the gingiva. Histologically, we'd see variable amounts of calcification histologically because it's an ossifying fibroma. The treatment for these is excision and removal of any irritants, but 15% can reoccur. And how is this similar? This is one of those 3 Ps that I mentioned, so these lesions are very similar. They're both benign fibrous mesenchymal tumors that are reactive, they present very similarly, and they're treated the same as well. But more importantly, how are they different, and how do we know that this is not the diagnosis for our patient's lesion? This has no association with pregnant patients. This usually doesn't bleed as easily, and it's more of a coral pink than a red. Another huge indicator that allows us to eliminate this answer choice was the fact that there was no radiographic findings for the lesion in this patient. Because this is an ossifying lesion, the calcified tissue is often visible radiographically, especially in a lesion of the patient's lesion size. The specific histopathology would allow for this to be definitively distinguished from a pyogenic granuloma, as we would see ossification or calcification rather than vascular granulation tissue. This is also only found on the gingiva, while pyogenic granulomas can technically be found on any body surface. Next, we have a peripheral giant cell granuloma. Again, this is a benign, fibrous, mesenchymal tumor that is reactive, meaning it's caused by local irritation or trauma. Clinically, this is also a painless, dusky purple-red and is only found on the gingiva of the alveolar ridge. Histologically, we would see granulation tissue with numerous benign multinucleated giant cells, and radiographically, if the lesion is large enough, cupping of the underlying bone may be seen. The treatment, once again, for this is excision and removal of any irritants, but 15% can reoccur. Once again, same similarities of the last 3 Ps that I mentioned. They're benign fibrous mesenchymal tumors, they're reactive, they present very similarly and are located and treated the same. But how are they different? Let's focus on those differences. This has, once again, no association with pregnant patients. This usually doesn't bleed as easily, and it's more of a dusky purple than a red. We also said that a large enough lesion may have radiographic findings, such as cupping of the underlying bone, and we know that the lesion the patient had no radiographic findings. The specific histopathology would allow for this to be definitively distinguished from a pyogenic granuloma, as we would see those multinucleated giant cells rather than that vascular granulation tissue. This is also only found on the alveolar ridge, while once again, pyogenic granulomas can technically be found on any body surface. And then lastly, this is a lesion that is different from the other 3, but it's also incorrect. This is a collagen deposition secondary to trauma that is also just known as a fibroma. So an irritation fibroma and a fibroma are kind of the same thing. Now, they're most commonly found on the buccal mucosa and tongue, but can be seen on any mucosal surface. They're smooth or slightly papillary, dome-shaped, sessile or pedunculated, and asymptomatic unless traumatized. The histopathology of this lesion would show a nodular mass of dense fibrous connective tissue, and these are treated via conservative excision. Now, how is this similar and how is this different from our pyogenic granuloma? They're both reactive lesions that form in response to trauma and are benign mesenchymal lesions. They present somewhat similarly, can be found in similar locations, and are treated the same way. But how are they different? Now, this presents as a pink or tissue-colored lesion and not as a red speckled lesion. This has no association with pregnant patients and does not commonly bleed. Fibromas also typically don't present on the gingiva as often. They're more commonly found in frequently traumatized areas such as the tongue or buccal mucosa. And finally, once again, the histopathology between the two would differ, so a biopsy will always prove what the diagnosis is. But when we have a patient with this raised, red speckled lesion on the gingiva that bleeds easily, she's pregnant, there's no radiographic findings, we're always looking at a pyogenic granuloma. Honestly, pregnancy is like the big clue for a pyogenic granuloma. If we were ever uncertain what benign mesenchymal tumor we were exactly looking at, a biopsy examining the histopathology would be able to provide a definitive diagnosis.